For 14 years, I was on lead-back medication, 400 milligrams for my leukemia cancer, CML. From 2018 to 2019, 1 year, I was on 400 milligrams of a generic version of lead-back medication, immaculate. My oncology doctor changed my medication after my 2 bone marrow procedures in December 2019. This is a short videos and education toolers of my new medication.
Priority in CML. Missing as few as 3 tablets per month can have a huge impact on treatment outcomes with imatinib. One study showed that for patients who miss 3 or more tablets per month, the probability of achieving MMR over 6 years was only 14%. For patients who were more adherent, taking more than 90% of their prescribed medication, the probability was 94%. So, is adherence that much of a problem in CML? Let's take a look at the Adagio study that included 169 patients with Philadelphia-positive chronic phase CML who received imatinib for an average of 4 years. Adherence was evaluated over 90 days in this study. When surveyed, physicians believed that on average, 93% of patients were adherent to imatinib treatment in the first month after diagnosis, and that 87% of patients were adherent after 1 year of imatinib treatment. So, let's see what the actual figures reflect. A total of 67% of patients were considered to be adherent to therapy at 90 days, with only 14% of these being 100% adherent to their prescribed imatinib dose. That leaves approximately 1/3 of patients who were considered to be non-adherent. CML is a complex disease with many different outcome measures. A diagnosed patient may undergo repeated and regular blood tests and bone marrow examinations to evaluate hematologic, cytogenetic, and molecular responses that indicate suboptimal or optimal response to treatment. Additionally, in order to provide patients with the most effective treatment at given times, we need to consider potential kinase domain mutations, patient comorbidities, concomitant medications, and risk level using the Hasford or Sokal score. But it is really important that we don't get lost in all these analyses and always keep the patient at the center of what we do.
This is the new cancer drug I am on. Today is the 5th day of January 2020. And today I can say I start my new cancer drug.
From an actual patient who was compensated by Bristol-Myers Squibb.
I'm Andrea Urban, and I live in the suburbs outside of Chicago, in a nice house that's right off the park, where my kids go a lot. I've been doing acting for 28 years.
It's a very beautiful family.
I'm still doing that now.
Andrea Urban talks about her journey with chronic phase Philadelphia chromosome-positive chronic myeloid leukemia, or CML.
I always worked out. I had just lost weight, I was catering and acting a lot, and things were going really well. And then I just noticed I was getting more and more tired. So I thought, well, I don't need to cater. I'll just do the acting. It's what I want to do. And I went to see the doctor, and led me to a bunch of other doctors until they finally did do a regular blood test. My doctor called me and said I needed to see a hematologist. And so I went to see this doctor, and she comes in. I've never met her before. She brings me into this office, and she says, you know, your blood results have come back, and you have leukemia. I said, wow. that appointment and I went right to Central Park in the rain. Sat down on a park bench. Was in shock for a while. Just kind of sat there. I immediately thought I had to go through traditional chemotherapy, radiation, and so I went to see this doctor, and she began to say about there's some medication in a pill form that you can take.
At first, Andrea was on Gleevec, imatinib mesylate.
That medication that they put me on, first of all, I'd be very tired, extremely nauseous. My face looked swollen. That's not good. Then there'd be all these other little odd things that would pop up. For additional income, I would sell knives, mops, things like that, and gather a crowd and then demonstrate. And so I was doing the sharp knives, and my hand would cramp around the knife. And then I would need to pretend as if it's nothing and get the knife out of my hand and then have to kind of get my fingers and press them down on the table to try to open them up. And I'm in excruciating pain to get my hands open and stretch them so nobody's noticing and I can still look at them, and then while I'm trying to solve this bad problem. I just thought that's really my only option, was just to stay on this medication. And then I see this new doctor when I come to Chicago, and she tells me, let's try this other medication for you and see if that doesn't help. I kept thinking Sprycel was a backup drug to what I had, and that I just had to accept what I was taking. When she said we should try this, then I thought, okay, that gave me hope. So I got information online and just talked to her a little bit more in detail.
Andrea is now on Sprycel, dasatinib. Sprycel, dasatinib, is a prescription medicine used to treat adults who have Ph-positive CML who are no longer benefiting from or did not tolerate other treatment, including Gleevec, imatinib mesylate.
I'm really glad that I trusted what my doctor said to try Sprycel. When I started taking Sprycel, yes, there was nausea and a little bit of a skin rash. And I found for me a lot of my side effects I was having before came down, really subsided.
Individual results may vary. Patients have had serious side effects on Sprycel, including low blood cell counts, bleeding, fluid buildup, heart problems, and pulmonary arterial hypertension. Other common side effects of Sprycel include diarrhea, headache, cough, skin rash, fever, nausea, tiredness, vomiting, muscle pain, weakness, and infections.
I'm really grateful. I can go to my auditions, I'm working, I'm singing. I have my house, my children, my family, friends, lots of love and support. That blows me away. That blows me away.
Ask your doctor if Sprycel, dasatinib, is right for you.
Chronic myeloid leukemia is a type of cancer that begins in the blood-forming cells of the bone marrow and then spreads to the blood. Eventually, the cancer spreads to affect other organs of the body. In the U.S., about 1 person in 526 will get chronic myeloid leukemia in their lifetime. The average age at diagnosis is around 64 years, and more than 50% of the cases are diagnosed in people 65 and older. Approximately 4,500 to 5,500 people are diagnosed each year in the United States with CML. Chronic myeloid leukemia is caused by a genetic defect, but this defect is not inheritable. To elaborate, chronic myeloid leukemia is caused by the swapping of DNA molecules between the chromosomes, which leads to the formation of a gene called BCR-ABL. This gene produces the BCR-ABL protein, which is the main culprit and causes the target cells to grow and divide out of control and spread throughout the body. Chronic myeloid leukemia has 3 phases: chronic, accelerated, and blastic. The symptoms tend to vary in nature and severity based on the particular phase of the leukemia in which the person is. Chronic myeloid leukemia normally progresses from the chronic phase to an accelerated phase and ultimately into a blastic phase over a period of time. Chronic phase is the earliest and easier to treat phase in which the person might not even have symptoms. In the accelerated phase, number cancer cells increase in the bone marrow and blood, and the person may suffer with fever, tiredness, night sweats, loss of appetite, loss of weight, spontaneous bruising, and pain in the bones. This phase can also be associated with changes in the vision, ringing sensation in the ears, periods of confusion, and stroke. In the blast phase, or acute phase, the cancer cells outgrow the residual healthy blood cells and platelets. In this stage, the symptoms are more severe, such as recurrent infections, spontaneous bleeding, swollen glands, lumps on the skin, and bone pain. For making the diagnosis, a complete medical history, clinical examination, and review of symptoms is necessary. Complete blood count is conducted to check the number of white blood cells, red blood cells, and platelets. Bone marrow test is done to diagnose the cancer activity and to find out how advanced it is. An abdominal ultrasound or CT scan gives information about spleen size, which enlarges as the disease progresses. Polymerase chain reaction test identifies the BCL-ABL gene, which is involved in the process of producing cancerous blood cells. The treatment goal is to kill the cancerous blood cells and restore healthy ones to a normal level. Imatinib, a tyrosine kinase inhibitor, was first introduced into the clinical trials in 1998 and has radically changed the treatment plan and prognosis for CML patients. In the treatment of chronic myeloid leukemia, tyrosine kinase inhibitors, or TKIs, are given first as they slow down the production rate of leukemia cells. Some commonly used TKIs are bosutinib, dasatinib, imatinib, and nilotinib. Other treatment options include chemotherapy and biologic therapy. Today, chemotherapy does not have a routine application role and is used only when the TKIs have stopped working. Chemotherapy can be given if the chronic myeloid leukemia is in the blast phase and as part of preparation for a stem cell or bone marrow transplant. Biologic therapy uses a medicine called interferon to help boost up the immune system. At one time, bone marrow transplant or stem cell transplant was a standard treatment option for chronic myeloid leukemia. Currently, majority of the patients diagnosed in chronic phase are manageable with TKIs and routine bone marrow transplant is not needed. There are several criteria to evaluate the necessity of transplant, which include the phase of the patient's disease, medicine tolerance, and the treatment response. In fact, the disease is effectively cured in approximately 70% of chronic myeloid leukemia transplant patients. For those that relapse, TKI therapy is the preferred course of treatment. For more information on chronic myeloid leukemia, list of expert doctors, hospitals, and ongoing clinical trials, please visit www.expertdocs.com.